Hello, I'm Dr. Roger Henderson. I'm a GP and I also co-host the GPnotebook study groups. Welcome to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now you can find us on all major podcast platforms, including Spotify, Apple and Google Podcasts, so do please follow us to receive notifications about new episodes, and if you're liking what you hear, do please consider leaving a review to help other listeners find us. Now in this episode, I'll be discussing postnasal drip, which I suppose is really just a descriptive term referring to the sensation of mucus accumulation in the throat or dripping from the posterior nasal cavity into the pharynx. Now it's important to say this isn't a diagnosis as such in itself, but a symptom that results from various conditions that affect mucus production or clearance. Now, as we all know, patients often present with a chronic throat clearing, coughing, a sensation of fullness in the throat, hoarseness, and sometimes even halitosis. Now, whilst being commonly associated with rhinitis or sinusitis, a postnasal drip may also reflect conditions such as laryngopharyngeal reflux or even environmental irritant exposure. Over the years, I've found that a structured approach to evaluating the patient with a postnasal drip is absolutely critical for effective treatment and symptom resolution. So let's remind ourselves first about the fundamentals of nasal secretions. We can sometimes forget that the nasal epithelium plays an essential role in our respiratory defense mechanism through the continuous production of mucus. And this surprisingly averages out at around a significant 1 to 2 litres a day. And this mucus is composed of water, glycoproteins, immunoglobulins, I suppose notably IgA, and enzymes. And it's secreted by goblet cells and submucosal glands, then transported posteriorly by ciliated epithelial cells towards the nasopharynx, where we normally swallow it without even noticing. So, any disruption in this system, and this is typically due to inflammation, infection, anatomical obstruction, or altered mucus viscosity, can lead to the accumulation of mucus, and it's this which patients then perceive as a postnasal drip. Symptoms usually become clinically significant when it causes a chronic cough, a sore throat, or a change in the voice, which then often prompts them seeking medical attention from us. If we look at the differential diagnosis for a postnasal drip, this is pretty extensive, and I think it's best understood by organising it into inflammatory, infectious, structural, environmental, and gastroesophageal causes. So I'll start with allergic and non-allergic rhinitis here. And the reason is that allergic rhinitis remains one of the most common causes of a postnasal drip, and overall is a very common problem indeed, affecting over 20% of the UK population. School-aged children and adolescents are more likely to have seasonal allergic rhinitis, whereas adults tend to have persistent allergic rhinitis. So in response to allergens, such as pollen, pet dander or dust mites, mast cells release histamine and other mediators, leading to mucosal edema, hypersecretion and increased capillary permeability. Now this mucus is often thin and clear, but can thicken with chronic exposure or even secondary infection. Non-allergic rhinitis, on the other hand, encompasses a group of disorders which are not mediated by IgE. And these include vasomotor rhinitis, triggered by changes in temperature, humidity or odours, for example, hormonal rhinitis, typically seen in pregnancy, drug-induced rhinitis, notably from topical decongestant overuse, and idiopathic forms. And all these conditions can lead to an increased nasal secretion and impaired clearance. Looking at sinusitis next, we should always remember that both acute and chronic sinusitis are important considerations in any of our patients presenting with a persistent postnasal drip. As we know, acute sinusitis typically follows a viral upper respiratory infection and then may transition to a bacterial process when symptoms persist beyond 10 days or worsen after an initial improvement. Mucopurulent discharge, facial pressure, and altered sense of smell are common findings. And in chronic sinusitis, the inflammation persists for more than 12 weeks, often with minimal systemic symptoms, but with a frequent mucus drainage and throat clearing as a presentation. Now, talking of viral upper respiratory tract infections, these frequently cause a transient postnasal drip too, through mucosal inflammation and increased mucus production. Now, although these are typically mild and self-limiting, symptoms may persist for up to 2 weeks, and a secondary bacterial infection can complicate the clinical picture. So, viral infections are easily picked up by us as causes of a postnasal drip, but I think this isn't always the case with another cause, gastroesophageal reflux disease and its variant, laryngopharyngeal reflux, which are increasingly becoming recognized as important contributors to a postnasal drip. In laryngopharyngeal reflux, acidic or enzymatic gastric contents reach the larynx and pharynx, but often without overt heartburn, which is why this diagnosis can easily be missed in my experience. Symptoms here include throat clearing, a sensation of globus, hoarseness, and a chronic cough. And just to further complicate the diagnosis, reflux-induced inflammation of the posterior pharynx can mimic or exacerbate postnasal drip symptoms, making our job even trickier. We must also remember too that dry air, especially in heated indoor environments, can thicken mucus and impair mucociliary clearance. Exposure to tobacco smoke, air pollution, cleaning agents, and occupational chemicals may all also stimulate excessive mucus production or cause direct mucosal irritation. Nasal polyps, septal deviation, enlarged adenoids, and obstructive lesions can all lead to impaired sinus drainage and chronic mucus accumulation. And in children, always remember the golden rule that a unilateral, foul-smelling nasal discharge always warrants evaluation for a retained foreign body. I'm always amazed at what children seem to be able to push up their nose. In adults too, persistent unilateral symptoms always require exclusion of a neoplasm, and this should always be a red flag symptom. Now, when looking at diagnosing a postnasal drip, we must remember this is primarily a clinical one that's then supported by a detailed history and physical examination. So key historical features to ask about here include the timing, duration, and character of the mucus, the presence of any associated symptoms such as sneezing, nasal congestion, facial pain and cough, whether there are any environmental triggers, any medication use, and even sleep positioning. Now, on examination, signs may occasionally include cobblestoning of the posterior pharynx, indicative of lymphoid hyperplasia from chronic irritation, although I have to say this isn't always present. Nasal examination may reveal mucosal edema, discharge, or even structural abnormalities. And in my experience, pulmonary examination is often generally unremarkable unless a lower airways process is also involved. If you want to look at further diagnostic tools, These can include nasal endoscopy to directly visualize posterior drainage, as well as sinus imaging such as CT scans in cases of suspected chronic sinusitis. For suspected laryngopharyngeal reflux, I usually treat this empirically with a short course of proton pump inhibitors before considering pH monitoring or laryngoscopy. So turning to the management of a postnasal drip, this is relatively straightforward as it simply depends entirely on addressing the underlying cause. So, in allergic rhinitis, for example, second-generation antihistamines and intranasal corticosteroids are the cornerstone of therapy. A nasal saline irrigation can assist in clearing allergens and reducing mucosal inflammation. And as we all know, allergen avoidance and environmental control measures are essential adjuncts. Non-allergic rhinitis may respond to intranasal antihistamines, anticholinergics, or corticosteroids depending on the specific subtype, and again, identifying and minimizing triggers remains critical here. Fortunately for all of us, acute viral sinusitis is typically self-limiting and only normally needs being treated supportively, with antibiotics strictly reserved for bacterial cases if appropriate, typically presenting with symptoms lasting more than 10 days or worsening after an initial improvement. Chronic sinusitis, on the other hand, may require a combination of nasal corticosteroids, prolonged antibiotic therapy, and in some cases, surgical intervention, such as functional endoscopic sinus surgery. In cases of suspected laryngopharyngeal reflux, lifestyle modifications, including weight loss, smoking cessation, head of bed elevation, and avoidance of late meals, should all accompany any pharmacological therapy. And proton pump inhibitors are typically prescribed for at least 8 to 12 weeks here, although response rates do vary significantly. And in those cases where we can't identify any clear etiology or symptoms persist despite our initial management, then referral to an otolaryngology or allergy clinic is warranted. An evaluation here may include allergy testing, laryngoscopy, and imaging studies. So that's a quick overview of postnasal drip in our patients, and I do hope you found it helpful. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments, or even ideas for future podcasts. Visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening, and goodbye.